Hello everybody. My name is Pete Marzano and welcome to the Nuvasive Virtual Spine Conference. We're pleased you could join us for an interactive discussion on adult deformity fundamentals with Dr. Okonkwo.
Thank you, sir. And thank you to the full Nuvasive team for putting this group together and putting this learning opportunity together. It's a pleasure to be here. What do you consider deformity fundamentals?
Yeah, that's a good question. I think thinking about the sagittal plane, correcting people into appropriate sagittal balance, those are kind of things I think about.
Yeah, good. Well, I'll tell you that it's a massively wonderful thing in modern times that there are so many moments for you all to engage and gain access to people who have been doing this for a while and to give yourselves a chance to learn something. For me, I'm hoping that we can spend a fair amount of time this evening talking about things that that in my experience really make the biggest difference. And frankly, it is the things that you do before you get to the operating room. And as time permits, we'll talk through some additional principles that I apply when we actually get to the operating room. But the fact of the matter is that the first and perhaps most critical portion of any procedure happens in clinic. And there's no amount of technical proficiency in the operating room that will overcome bad decision-making on the front end in clinic and during the evaluation phase of taking care of a patient with a spinal deformity. And as all of you emerge into your practices or further your practices or mature your practices, you will have failures. It has happened to every single one of us. And along the way, we learn from all of these problems. I can look at an x-ray from my own practice and get very, very close to predicting the year that operation was performed, because of how much things have changed and evolved since the early days. And I remember about 6 or 8 months ago, I was looking for a particular slide from a talk I knew I had given many, many years ago. And I went and drudged up an old scoliosis talk of mine from about 10 years ago. And I just walked through that talk and realized I have learned so much now compared to 10 years ago. There are so many decisions and so many interventions that I would have done differently or made differently if I knew then what I know now. But again, no amount of technical prowess, no amount of sophistication, no amount of assistive technology will overcome bad decision making in clinic. And whatever can go wrong will go wrong. So let's think through lots of things about deformity fundamentals. But patient selection is number one, first and foremost. Surgical planning, alignment and understanding the goals, having a fundamental understanding of the approaches and what each of the various approaches can and cannot do for you as you try to achieve your goals. And then there are also surgical challenges that we will all encounter in the operating room that we need to overcome. But if we start with patient selection and identifying surgical candidates, this is one of those things that for me really only came at the very, very end of residency, and frankly, I didn't get enough of, and I had to spend a tremendous amount of time maturing my approach to clinic and my approach to patients in the outpatient setting. And there really is no substitute for a thorough, proper, fastidious approach to clinic and the preoperative evaluation and selection of patients. And we know that there are a whole host of factors that go into what is going to affect success in the operating room. And we know that a lot of these factors fall into modifiable and versus non-modifiable categories, where, you know, obviously the non-modifiable ones are things we cannot change, and God grant us the courage to to face those things and the wisdom to understand what those things are that we cannot change. But there are so many things that go into the patient selection process in clinic, and working through so many things that that impact success in the operating room as defined by the patients you select and the choices you make in clinic. So, you know, John, you've been in practice for a couple of years now. How prepared would you say you were when you stepped out of your fellowship training and emerged into month one of your practice?
Completely unprepared, but a lot better prepared than I would have been had I not done, spend time with Dr. Shaffrey. What I've learned in spending time with Dr. Shaffrey is the importance of kind of following patients long-term, developing a relationship beforehand, and we would see them throughout the different stages. You would see the patient who came in, was meeting them for the first time, just discussing with them what their goals are, setting expectations, making sure they're realistic. And then we'd see patients, who are immediately post-op, who are dramatically better than they were before. And then the ones 5-10 years later who may have had some issue or complication in the interim, but are still grateful that they're kind of being taken care of. But, I think the ability to kind of spend a lot of time talking to patients and being with somebody who's, a master is kind of, it prepared me as much as I could, but I wasn't ready at all. And
look, I've been doing this for 14 years now. I started my residency 20 years ago. The two hardest years of my life were PGY2 and my first year in practice, without question. Yeah. And, in retrospect, chief year was just a remarkably enjoyable experience. It was a neurosurgical smorgasbord where I walked in every day and had my pick of whatever it was I wanted. But that first year in practice was a significant challenge. David, how's it been for you this year?
Yeah, it's definitely been challenging. It's just echoing what you said. I mean, chief year, throughout residency, I did maybe a total of 3 to 6 months of clinic across 7 years. And then, chief year, the emphasis was all on operating. But I really feel like the moments that really paralyzed me this past year have been the decision-making and trying to figure out what to do and when to do it. And that's really what I'm struggling with the most right now.
Yeah. Well, you each will devise your own system and approach to this. You will all get better at this. I am way better at this now than I was 5 years ago. And I know that even Chris Shaffrey is better now than he was 5 years ago. And 15 years from now, I'll be better than I am now and everything else. But taking the time in clinic to maximize the likelihood of success is fundamental in the management of spinal deformity. And so David, have you started to come up with some parameters? Do you have expectations in your practice for patients with it when it comes to BMI?
Nothing formal, but I try to, just based off of what I see and discussions like this and do conferences, people who are severely morbidly obese, I try to establish a ceiling for them. So there's a number of patients where I just tell them you're too big, we can't do this right now. So usually BMI cutoff for me is around 40 or so. Yeah.
Well, I'll just walk through each of these and give you guys where it is that I've fallen out at this point. And I'm in a bit of a luxurious position that I can impose some relatively significant expectations on my patients. And I have a practice that's busier than I need it to be. And it's probably busier than I want it to be at this point. So, for me, it's really, truly a focus on making sure that each of the patients that actually end up in the operating room are in a position to have the maximal success and outcome. And so for me, I have a BMI cutoff of 32. And why did I pick that BMI of 32? It's because if you start to summate the data that's out there, you start to see that there is this inflection point at around a BMI of 28, but then there's a secondary inflection point right around a BMI of 32, where the impact on wound healing and wound infections starts to rise. And one of the great things about what it is that we do is you can find any paper that justifies anything that you want to do. So you will find papers that say there was no impact of obesity in this particular series, et cetera. But if you summate the largest group of data, and especially if you broaden it beyond just focused on spinal deformity, and you start looking at multiple surgical disciplines, there is this second inflection point around a BMI of about 32 where wound complications and wound infections really starts to rise. And I always approach not just the BMI, but many of the things on this list from a very specific perspective with the patients, where I am saying to them, your health is a team sport. You have a job, I have a job. Many times the first job is the job of the patient, and my job comes later. And for every one of these factors, I say to the patients that I will walk this journey with you. There are some very difficult decisions that we need to make now. There are going to be some difficult choices that need to be made, and some significant changes in your life in order for us to make you a surgical candidate. And I will help you every step of the way achieve those goals, because we both have the same goal, which is for you to have a better quality of life after a successful intervention for your spinal deformity. And it's really been amazing to me how frequently and our patients will actually hit that BMI threshold of 32. And there is a very, very strong correlation between the patient's commitment to reaching that particular target and the likelihood of success. It can also be a remarkable screening reality that the patient who is unwilling to take responsibility for his or her own health and focus on achieving those health targets that are going to increase the likelihood of success, that can be a very strong indicator to you that may not necessarily be the kind of patient that you want to then take responsibility for down the road when something doesn't go exactly as planned. And whatever happens in that situation, you own it. If you take this person to the operating room and a complication occurs, there is no finger pointing to any other person besides you. So
Dr.
having
Okonkwo?
that, yeah.
Excuse me real quick. Matt, would you like to ask the question from our chat room from Dr. Quinones?
So Dr. Okonkwo, Dr. Quinones has a question. He operates down in the Midwest where BMIs are pretty much always high. He's wondering, should we raise our cutoff to match our population? We serve knowing and taking on the increased risk, or say no to our patients?
That's a great question. And I live and work in a region that has plenty of people who whose BMI starts off as greater than 32. I don't view this as saying no to a patient. I view this as educating the patients to understand what the implication of these factors are. And I'm not saying no to operating on them. I am educating them that the risk profile for surgery at their present weight is untenable, and that we need to achieve those weight targets together. And let's say that the patient is 63 years old. If you understand the insurance data in the United States of America, a 63-year-old female has a life expectancy of almost 30 years. And helping people understand that the impact that their spinal deformity has had on their quality of life, viewed through the lens of a 30-year expectation, the people who really need these operations understand that they can't live 30 more years with the pain and the disability that has been wrought on their life by their spinal deformity. And helping them understand that taking the time now, whether that is 6 months or 9 months, or even if it's a year, but taking the time now to maximize health and maximize the likelihood of success by going after these modifiable risk factors is going to have a 30-year payoff. So I'm not telling anybody no. I'm educating them that at present, they are not a surgical candidate. And they're not a surgical candidate for factors that we can control, factors that we can change in order to hit the success metrics that all of us are looking for. The patient first and foremost. That's a great question. And anybody can feel free to chime in and interrupt me and ask a question at any time. Like I said, I'm in a bit of a luxurious situation that I can set these relatively high metrics, and you know, this isn't binary. This isn't that there's low risk at 32 and absolutely unmanageable risk at 33. It is a spectrum, but if John's working towards 33, it's better than 38, and it's better than 41. I hear that perspective a lot, that people are working in competitive environments, and so they have to be very careful about their selection process so that it doesn't affect their volume. But I would just say, especially as you are getting started in your career, I don't really think it changes later on, but I think there is an added extra special importance early, that you will be judged by your outcomes, and your reputation that you develop in the first few years will be difficult to shake if you're developing the wrong kind of reputation. And so you are better served losing a patient who is less committed to his or her health. You are better off losing a patient who isn't as committed to her health as she expects you to be to her health, than you are taking chances on people who are unwilling to make choices and intervene in their health, in their own health, to create a better risk profile for themselves. Yeah. Any other questions about weight?
Actually, Dr. Okonkwo, I have one. In terms of the last 14 years in your practice, has it been a slow evolution from these high BMIs, 45, and worked your way down to 32? Or was it more one day you took a look at the data and kind of went from 40 and said, hey, 32 is the cutoff, I'm no longer accepting a patient population above that?
Yeah, well, I can tell you is that I understood this from the get-go. What I got better at was the process of educating patients about the value of taking ownership over their own health. And all of us are empathetic, and all of us have a heart. And you're spending time in clinic with someone who's truly suffering, and then you're having to ask that person to suffer longer in order to lower a risk profile for surgery. And what's changed in my practice is that I was much more inclined to disregard a certain factor in exchange for my deep desire to help that person. And I learned the very, very hard way that the ultimate responsibility is with me, and that shirking certain things and cutting certain corners and then having bad outcomes, that I have not served my patient well by engaging in things that I knew up front carried with it high risk, and I didn't remain faithful to my own principles, that I allowed my principles to be affected by empathy. That's what's changed. It wasn't a light switch. It was frankly getting burned by people where I went a step further than I should have, because I sympathized or empathized with their suffering, wanting to help them, without realizing that helping them 4 months from now would be as effective over 30 years. So now what I will often say to people is, 20 years from now, you're not going to remember if you had surgery in May or you had surgery in September. but you will remember for the rest of your life having to have 1, 2, 4, 6 additional operations and spending 4 extra weeks in hospitals because of a wound complication or an infection, because we didn't take that time up front to put you into a more advantageous position. Yeah, and I'll tell you that the nutritional status dovetails right alongside that. This one was a little bit more driven by data. We started to see these reports out there about how prealbumin was a more effective assessment of nutritional status than some of the other more traditional parameters for looking at nutrition. And so we implemented a process where we added the prealbumin to all the pre-op lab orders that we were doing in our deformity population. And we first did this retrospectively. So we added it to basically the standard checklist. And then 3 or 4 years later, we went back and said, okay, we've been doing this for 3 or 4 years. Let's look back and let's see whether there was a relationship between the preoperative prealbumin and the risk for wound complications after surgery. And we saw this, we saw this very strong association between those things. So it was a retrospective look at a prospectively collected set of data. And once that pattern became crystal clear to us, we switched to, if we identify someone with a prealbumin less than 20 during the preoperative evaluation, we actually stop this. We postpone the surgery and address the nutrition up front. This process has been significantly facilitated by the parallel maturation of our Center for Perioperative Medicine, where we now have this fantastic group of anesthesiologists who actually are committed to the prehabilitation of patients who are undergoing major complex surgery in our institution. And I was formerly having to do this myself, creating nutrition plans, finding dietitians, engaging primary care doctors to work with us on this. But now I have a group of anesthesiologists who work in our Center for Perioperative Medicine who contribute to this process with us. So it's taken a little bit of a burden off of me. I feel like it saved me in a couple of circumstances. I've had one particular patient where it was so unbelievably obvious that they were malnourished that we didn't have to check a lab value in order to intervene. But this has been a bigger part of our practice. I have a great group of teammates with advanced practitioners and nurses, and one of the nurses on my team in particular is just incredibly thorough, and she's the one that flags all these things for me, and then reaches out and pulls me aside, and she's just tracking all of this stuff invisible to me until she pulls me aside to say, hey, by the way, so and so who's on for next month, her labs came back, she's got a prealbumin that's 16. Smoking status. So for those of you who are already in practice, so we'll come back to you in just a second. Tyson, are you operating on smokers?
On certain things. I mean, for most things, fusion type procedures, I have that conversation similar to what you were describing before. I say, whether we do this surgery tomorrow or we do this surgery 3 months from now, I think it's the same surgery. You want to decrease your perioperative risk. So I try to get people to quit smoking for 6 weeks. Easier said than done, but we have an optimization program that helps us in that regard. I think there's some newer studies that show some of the even if people can switch to patches or Chantix, things like that, I think they've got better results than if they continue smoking.
Yeah, how about you, Brian?
So it's much more important for me to make sure that the patients stop smoking after surgery before I strongly encourage them. But then if they continue to smoke up until the point, I still have to make sure that they stop smoking. For myelopathic patients, obviously we can't wait, too long. So I still got to bite the bullet and do it, even if they continue to smoke. But, I continue to encourage them. For patients that can wait for more routine non-urgent elective cases, yeah, they must have, done smoking cessation before surgery actually takes place.
Yeah. I view smoking as a non-negotiable non-starter.
Absolutely.
Those are the exact words that I use with patients.
Yeah.
As Tyson pointed out, exceptions are made for the myelopathy population. But even in that population, I do my very best to engage in a smoking cessation strategy, even if it's for the 3 or 4 weeks in between when I see them in clinic and when they're coming back for their operation. And we also have a smoking cessation team in our hospital who round on smokers in the hospital and offer them smoking cessation intervention strategies. I find this to be right up there with BMI. We know that smoking has a negative effect on wound healing, on bone healing, on arthrodesis, and so especially in the spinal deformity population, smoking is a non-negotiable non-starter in my life. And it's reached the point that again, the folks on my team who often have contact with the patients before they come to meet me. Jacob was with me in clinic today, and we saw a patient, and I asked him, "Are you smoking?" And he said, "No, your PA told me when I talked to her on the phone a couple weeks ago that you wouldn't operate on me if I smoked." And so the guy quit in the 2 weeks before in the 2 weeks between when he spoke to my PA and when he saw me in clinic. David, do you have an approach to this? And if you don't operate on smokers, how do you verify smoking cessation in your practice?
Yeah, so same as you, smoking is non-negotiable, and I generally have them get a preoperative nicotine and nicotine test at least 1 week before surgery, and then for the larger cases, I'll order a drink follow-up as well to make sure that they stay off of it.
Yeah. Matt, what do you see yourself doing when you get into practice?
I think something similar. I think especially if you're talking about a fusion type procedure, you want them to quit smoking and probably would not operate on somebody electively if they were actively smoking.
Yeah. My partner, Adam Cantor, checks the urine for nicotine metabolites. I actually don't order an objective test to verify. I simply ask the patients. And then I explain to the patients that if you are going to lie to me about smoking, we don't have a doctor-patient relationship. And ultimately, lying to me about this really doesn't affect me nearly as much as it affects you. And I try to group it with everything else. That I think that the greater extent to which the patients in my practice take ownership and responsibility for their actions and their health, the stronger that partnership is going to be, and the higher our success rates will be on the back end with surgical interventions, all against this backdrop that the decisions we make, the changes we institute ahead of time all end up having a stronger effect on the outcome than the technical performance in the operating room. The technical performance in the operating room is almost going to fulfill its own prophecy. We'll occasionally make a mistake in an operating room. That's true. But you can technically execute the perfect operation in the operating room. And if you have cut corners or made mistakes on the front end, none of that technical prowess will overcome the stuff on the front end.
David, what's your opinion on other nicotine products like vaping or these nicotine patches, et cetera? I've gotten into debates with other people. Some people feel that it's the nicotine that's the most destructive. Other people feel that it's really the combustion products and cigarettes.
Yeah,
what are your thoughts about it?
Yeah, it does appear as if the anti-inflammatory actions of the toxins in smoke have their own negative impact, but the nicotine itself is also negative. that has been an evolution in my practice. I was previously focused purely on smoking cessation, and I was willing to tolerate people who had switched to a patch. That was in the days before we had, vaping. I then moved away from that. When vaping started to become more popular, I had a brief period of time where I tolerated the smoking cessation in favor of vaping, but it's quickly become clear that nicotine itself is harmful, and that vaping doesn't change that harmful effect of nicotine on healing from surgery. So there are non-nicotine based vaping products, and that would be okay in my practice. But anything nicotine containing, whether it's smoked, vaped, or absorbed through the skin, is a non-negotiable non-starter at this point. Look, this next topic, narcotics, is, wow, is this ever a big deal? First of all, we have very unique and special challenges in the United States. As many of you know, at UVA, where I trained, we all go overseas for a year. The year before our chief year, I spent my year in New Zealand. One of the things that struck me remarkably about my year in New Zealand was that I never prescribed a narcotic once. I did 500 operations, not one single narcotic. And it has now become crystal clear that we are virtually the only country in the world that has this issue of widespread narcotic prescriptions. And so for us, so many of our patients are on narcotics before they ever meet us. And we're starting to gain this clearer picture that the higher your morphine equivalence consumption of narcotics is before surgery, the more challenging it is to engage in pain management in the early postoperative phase. But we're also now starting to see more and more papers emerge in the literature that shows a direct relationship between morphine equivalence before surgery and worse outcomes on patient-reported outcome measures after surgery. So this is the more recent thing that has taken on added importance in my life. I've been focused on every other thing on this list for a long time. This has really become much more front and center in my practice, where we are now viewing this as, how do we work with our pain management doctors who are committed to these things to wean people down on their narcotic usage prior to surgery. Does anybody want to comment on patterns that you've seen, Laura? Anybody? Have you seen anything in this regard at Duke?
Not at Duke. I trained up in Michigan, and we actually did an analysis of the insurance data for the country from that Tuven market scan database. And they found that exactly what you're saying, that the higher your morphine equivalents are going into surgery. And then there was this interesting correlation around the 6-month mark. If you've been on them for 6 months or longer, your likelihood of being prescribed them after a year after surgery was virtually 100%. So I think it's that combination of duration, intensity, and then on top of it, it's all like everything you're talking about. It's a marker for the patient, whether they have an external locus of control or whether they take ownership for their own health and outcome. So yeah, I think and hopefully as that perioperative mindset expands across the country, that'll become part of the ultimate workup beforehand that can help engage patients to wean down. But I think for certain people, they say that the 25% wean is a good goal in the month before surgery. I guess depends on how high and how long the patient has been addicted, or whether they are.
Yeah, that's an interesting point about, what should be the target of how much opiate weaning needs to occur. I don't know the right answer to that, and I haven't instituted sort of rigid targets in my practice for what I'm looking for. I just want people to be on less. and then they ask me, well, how much, how much of this am I supposed to get rid of? And I say, well, as much as you possibly can. and then we actually steer them to a short list of pain management providers in our city that, as I hinted at, I trust, because I know that they are as committed and engaged into this process, and who understand what that data that Laura just mentioned indicates. And so we actually shift the patients over to them ahead of time, and hoping that they can get people down on narcotic consumption before the operation. All right. Well, I'll have more to say about narcotics in the years to come as we build out this practice. Nitin's on the line. Nitin, you want to say anything about the 1,700 papers you've written on this subject in the last 8 months?
Well, I mean, we've been asked what is the dosage to reduce it to, and we don't have that answer. But as Dr. Okonkwo said, that looking at our people in the past and reviewing them, when we look at people's morphine equivalents and those who are chronic users for greater than 6 months, they all seem to have lower patient-reported outcome scores. So I think that's our next step forward, is instituting a prospective study, establishing what is the target to get them to.
Yeah. All right, bone health. So Tyson, are you checking DEXA scans in your patients in your practice?
I am. I'm ordering a lot of DEXA scans. I think the office that I'm at now, they were. I had to teach them why we were ordering DEXA scans. I think that was a relatively new thing. I've had one bad outcome with someone who was osteoporotic and less threshold to order a preoperative DEXA, and I've referred a few patients for 6 months of Prolia prior to uninstrumented fusion.
Yeah. 2009 was the first time that I placed a deformity patient on Forteo, and she was the matriarch of a prominent business here in Pittsburgh. And I explained to her that I don't fully understand what the implications of this are, but there is some early indication that for someone in your situation, this will be of benefit. And it all again works against this backdrop of, we are trying to make choices and perform interventions now to maximize the likelihood of success after the operation. She was a willing participant. I will usually release these patients after 5 years, but she actually insists on coming back to say hi and thank you every single year. So I see this woman every single year. And I even said to her at her 10-year visit, I said, you can skip a couple years. And she said, nope, I'll be back next year. But she did fantastically. And of course, that's an anecdote, right? But it really was helpful to me that the first time I did this was a resounding success. Since then, it's really become systematic. And for patients who have T-scores less than -2, we engage, again, a small group of endocrinologists, and there is one rheumatologist in Pittsburgh who are very wonderful collaborators with this. I send them over to these folks. They get them through the proper evaluation, get them onto Forteo or Tymlos, or now there's the new one. So we now have 3 options for in that class that used to just be Forteo to try to intervene on bone health. It is unclear to me what the duration prior to surgery needs to be. When we surveyed this in the ISSG group, it was everything from I want the patient for an entire year on a bone density management medication, all the way through people who just wanted it 1 month ahead of time. I've settled on to this. My goal is 3 months ahead of time. I will tolerate 1 month ahead of time, but I really just want the patient on it before we do the surgery, and so that they can carry it through for at least a year and typically 2 years after the operation. This is something that has really become a part and parcel reality in my practice, and it has served me extraordinarily well to be very aggressive. The insurance landscape has become more favorable. I think insurance companies can also see the value of spending the money on something like Forteo or Tymlos to avoid the costs associated with revision surgery. So this has been a big deal in my practice. And then the last thing on this list, yeah, sorry.
I just had one question on that. What's your indication, or what's sort of your trigger to start that process for someone maybe with without previously diagnosed osteoporosis that's seeing you with a, you know, even a deformity or even just a degenerative case? What would be your indication to say, okay, I'm going to get a DEXA? Are you just looking at plain films, or
no?
Can you touch on that?
So my practice has a very, very high percentage of deformity patients.
Okay.
And even when I'm doing small surgeries, it's typically I'm doing a small operation in someone with a spinal deformity who doesn't need a deformity correction, right? They're sent to me because of that scary word scoliosis, and then I see them and I realize you just need a 4 or 5 T-lift and you're going to be fine. Or you may have this wicked thoracic curve, but your real problem is your spondylolytic spondylolisthesis at L5S1. So even when I'm doing 1-level surgery, it's usually in a deformity patient. And so we've just added this. People don't even come to see me for their first consultation with me without a DEXA scan if you are over the age of 45. So I'm not doing this to the teenagers. I'm not checking T-scores in teenagers, but anyone over the age of 45 de facto gets a DEXA scan in my practice. And almost always before they come to see me. And if they hadn't, it's because we told them to do it and they didn't before they came to see me. And then mental health. I mean, there are so many correlations between mental health and challenges with spinal deformities, pre-op and post-op. It complicates the coping strategies on the front end. It complicates the recovery strategies on the back end. I approach mental health through the lens of these are realities. People will tell me I am depressed because of how much pain I'm in, and I will say, please go back out to the waiting room. You'll meet 20 other people who are having just as much pain as you are from their spinal deformity, and they're not depressed. Deformities don't cause depression. Depressions don't cause deformities. These are true, and unrelated. They are horrible friends. They are not nice to each other. Having depression and having a spinal deformity can exacerbate both of them, but neither causes the other. So you are not depressed because of your spinal deformity. You are depressed because you have major depressive disorder. And then I mandate that anyone who carries a mental health diagnosis, a mental health disorder diagnosis in my practice to have their mental health provider send me a letter clarifying the diagnosis, clarifying the treatment plan, and describing the patient's compliance with treatment expectations for mental health, and then to finish it off with a statement of whether their mental health provider believes that this person's mental health is in a sufficiently stable, treated place to undergo the behemoth of an intervention of spinal reconstructive surgery. Any thoughts from anyone who's joined?
Hey, David, this is Vainu Namani here. Sorry, I was a little late. I just got done with a case. I'm one of the surgeons at Virginia Mason in Seattle. Yeah, this is a really interesting problem, because patients with mental health disorders, as you said, are really ubiquitous. Not only in deformity, but also in degen spine. And we published a paper actually earlier this year in Spine Deformity, looking at how many patients have comorbid psychological conditions, and what we showed is that if you look at all the patients, only 17% had a combination of realistic expectations for surgery, and did not have a history of mental illness. And so it's really a tremendous problem, you know?
How are you assessing expectations? Because I would actually, when you see this "what else" question down here, that's a remarkable thing, right? That I would add patient expectations as a modifiable factor in the preoperative evaluation of the patient with a spinal deformity. So how are you measuring? How are you measuring patient?
Factor. I think that, you know, what we actually do is we have neuropsychologists that we work with here, and we actually formally screen every single patient undergoing a complex spine surgery. And this is part of our kind of multidisciplinary spine conference that we have. And our neuropsychologists actually attend those conferences. And basically what we do is we look at, you know, whether or not people have realistic expectations, what comorbid medical conditions they have, what sort of support system they have at home. And what our neuropsychologists do for us is actually assign a color grade, looking at, you know, basically it's like green, orange, or green, yellow, orange, or red. And that's how we kind of try to risk stratify which patients have big, have a psychological condition that is bad enough, in addition to their expectations, where we might put a pause, or we might try to have
so what do you do next? What do you do next when you identify the patient who has unrealistic expectations?
It depends on the problem. So a lot of times it's a support system. Actually, you know, you have the patient who's depressed and isolated, and like you said, you know, doesn't really know what they're getting into in terms of these kinds of operations, and they come to the visit and they're by themselves and they don't have any family members nearby, and so we usually tell patients that that makes it really, really hard to recover from this kind of surgery, you know? And so we try to, with our nurses who are heavily involved in these patients, reach out to either family or friends. And we actually, you know, ask them to bring a friend to our pre-surgical education class where we talk about this stuff, just so someone else is involved in their care. If it's depression, we don't, you know, we don't withhold surgery for that, you know, obviously. But we certainly will make sure that they're optimized as much as possible, like you said, you know, with either their primary care doctor or with their psychiatrist or psychologist.
So that, to that point that you just made a moment ago, I do not sign patients with spinal deformities up for surgery by themselves. That I insist that they have someone else from their social support structure. And that person will be different. Sometimes it's a spouse, sometimes it's a daughter. It is very rarely a son, but that does happen on occasion. Or there are people who don't have a good family support structure, but they have an alternative social support structure. So they bring, you know, their closest friend or their next door neighbor with whom they have a very strong relationship. But I will not sign patients up for surgery, for spinal reconstructive surgery, by themselves. There has to be someone else there with them. And this is after, you know, the average patient in my practice is in my practice for 9 months before the operation, as we work through iteratively everything. So it's typically 9 months between when I first meet them and when they actually end up in an operating room. And of course, we're operating on only a small percentage of the global number of new patients that are seen. And so by the time we get to that point that we are ready to talk about surgery formally and finalize things and do the consent process, I've already known these people for several months. And then at that point, if I haven't already met the correct person from their social support structure, I insist that they return for that visit with their social support structure with them. That has saved me on many an occasion. And there have been other times when that is the person who clues me into yes, she is in fact still smoking, for example. But there are also times when that highlights that, you know what, we're not going to succeed here because we need to take some time to create the proper pathway for you after surgery for you to safely recover from this, rather than you just being unleashed onto the world all by yourself and end up readmitted to the hospital because you can't cope with the recovery process on your own.
Yeah, I completely agree with the exact same thing. And, I think we all know that what doctors tell patients and what patients actually hear are often two completely different things. And just having a second set of ears to listen to all of the terrible things that can happen, in a spinal deformity operation, I think is really important for people to have realistic expectations and to fully understand the risks.
Yeah. So look, what do you know? We consumed the hour off of one slide, and let's just pull all of those principles together with this patient of mine, whom we'll call Carl, as Carl manifested with so many of these modifiable and non-modifiable risk factors that we discussed. So Carl's 64 years old, 5'6", 165 pounds for a BMI of 27. He has not had previous spine surgeries, but he has had previous surgeries in other body parts. And he presented in March of last year with complaints of severe low back pain. I had actually previously met him in 2017 and discussed with him why he was so far away from being a surgical candidate. He returns in March 2019, continuing to complain of severe low back pain and inability to stand erect. He had a remote history of IV drug abuse in the late 90s. And prior to 2015, he had diabetes type 2 and weighed 380 pounds. So he got a gastric bypass and subsequently lost 200 pounds. At the time, he was a smoker, and in fact, smoking was one of the ways that he maintained his sobriety from IV drugs. But again, I had met him back in 2017 and talked through lots of things with him. At that point, he hadn't achieved the full 200 pounds from weight loss from gastric bypass, and he's on very high doses of narcotic pain medications. So at this point, Carl re-engages and goes through a whole host of goals that we had talked about a few years earlier that he had achieved, but there were some additional things that we then needed to look into. And again, so we needed to address his preoperative nutrition status, because you can imagine with gastric bypass and losing 200 pounds, you're at risk for malnutrition, you're at risk for osteoporosis, that plus the previous long history of packier history of smoking. And we also needed to address the fact that he had to wean off of his high doses of narcotic medications. Turns out he had severe osteoporosis and was continuing to struggle with anxiety and depression, which he was actually pretty upfront and open and honest about. So he's got clear pathology. It's obvious that Carl is having severe disability related to his spinal deformity. What you didn't see is an X-ray from 2012 that showed him having a perfectly straight spine. So this entire deformity is de novo. And so we worked through every one of those factors with Carl. We got him into an appropriately nutritionally optimized state. We got him into more rigorous treatment for his anxiety and depression. We got him onto Forteo. He nearly weaned off of narcotics. He re-engaged and identified a new mental health provider and met every one of the expectations that we laid out in front of him. And he ultimately had surgery in November of last year, successfully. So any comments, any questions, anything that anybody else wants to talk about? You know, there's so many times that we focus on the tools and the metal and the implants and everything else in the world of spinal deformity and in these educational programs. But the fact is that the single biggest predictor of success is what you do in clinic and how you set up your patients to achieve success from all the great things that you guys have learned how to do in the operating room. So any questions, any comments? David, thoughts?
I have a question.
Yeah.
How are you assessing patient frailty?
Yeah, that's turned into a pretty big deal at UPMC. There's a general surgeon named Dan Hall who has basically made this his life force from an academic perspective, but also a systems perspective. Nitin's with us. Nitin is actually putting the finishing touches on a manuscript that we're putting through. So we have what's called the RAI, and Nitin, you want to describe how that gets approached in UPMC, and it's done for every single patient. And in fact, in our system, you can't. And Nitin, you're on mute if you want to come off mute. But in our system, you cannot actually see a patient without acknowledging in the electronic medical record that you have reviewed the frailty score that gets produced. Yeah, but Dan Hall in our institution, Nitin, you want to comment on it?
Yeah, so we, Dan Hall, Dr. Hall is a general surgeon, but system-wide UPMC in July, in the routine screening of patients in clinic, started engaging clinicians in reviewing these frailty scores. So every patient encounter, the frailty score pops up and it notifies you, alerts you if they're in a zone that you should be concerned about. And these patients are categorized in frailty, in different frailty categories, broadly speaking, whether they're non-frail or they're frail. And for the most part, we've been able to see that we are successfully able to identify patients that we're going to be able to safely take through surgery, regardless of their frailty score. But in certain circumstances, those that have an extremely high frailty may be risk stratified to optimize them prior to surgery through a prehabilitation screening and clinic. So we again have this luxury of this Center for Perioperative Medicine, where we now have a resource. So when we identify a patient that is screening as having high frailty, we actually have a process in place to refer them for a deeper analysis of that frailty, and then to create a structure and plan to try to lower their frailty. There are times when the frailty there are times when their frailty can't be modified, right? But there are other times that frailty can be made less frail. It's also just another added little data point to factor into the preoperative counseling. And I haven't necessarily taken that numeric score that gets pumped out and walked into a room and said your frailty index is 71, and therefore you have this X% risk of a 6-month mortality. I'm not doing that, but I'm factoring that into what all of us also just inherently understand. You know, when you walk into the room, when you're communicating with someone who is extraordinarily frail, and helping people understand why you can't help them, but then trying to offer them some other alternative to surgery to just help even a little bit with their quality of life. It is as important to know when to say no. Yeah, we have the luxury of having this built-in system that does an automated frailty score for us before we even see the patients. Other questions?
I have a question real quick. So it sounds like you go through a lot of steps, and there are a lot of criteria that patients have to meet before you take them to the OR. And you mentioned 9 months you have a relationship with the patient before they actually get to the OR. How do you do all of that efficiently? Do you have a team of PAs and MPs that see and triage all these patients, or are you doing them yourself? Or how do you get it done efficiently?
I would not use the word efficient to describe what's happening in my clinic. And in the pre-COVID era, my clinic was a true waiting room. Maybe should even be viewed as a hotel. Like, check in, it's unclear when you're getting out of here. And I feel terrible about that. Really, I do. And we know that wait times have a huge impact on patient satisfaction and HCAP scores, et cetera. And the patients complain about it. But they will also say, yes, I waited, but the doctor gave me as much time as I needed. And it can be viewed as a problem that I freely admit to. And I freely admit to people, I will sit here as long as you need me to sit here. I will sit here as many times as you need me to sit here to ensure that you are in the position to make the best possible decision for your health. It has a spillover effect that I am late in clinic. Now, the COVID-19 era has done something interesting in that it was actually in February that we were starting the process of structurally creating a more robust telemedicine process. And it ended up being perfect timing because we were about to pull the trigger on a more robust telemedicine component to the practice that then just got flipped into overdrive. And I've noticed that telemedicine is actually introducing some efficiencies that don't exist. You know, when someone drives 3.5 hours to see me in clinic, they can't have a 15-minute visit. It just doesn't work like that. The dissatisfaction of only spending 15 minutes with me when they've spent 7 hours in the car back and forth doesn't work. But connecting with someone that I've already met a couple times, connecting with them with 15 minutes over telemedicine is a vastly more effective 15 minutes. And the patient experience of that 15 minutes is far more rewarding. And they're willing to accept that 15 minutes. Even sometimes it happened to me this morning. At the end of 15 minutes, the patient was like, hey, you know, I got what I need. Appreciate it. You know, see you later. Move on with your day. I have known for a long time I need to get better at the efficiency in my clinic. But at the same by the same token, I have been unwilling to compromise on the investment of time necessary to establish relationships, to build trust, to confirm the rapport, and to impart upon patients that true, genuine belief that my pure, simple, singular goal is to do what I can, working with them in a team sport fashion to maximize their quality of life. But my efficiency would historically be rated as exceptionally poor. Now, my patient viewpoints, you know, the patients will say ridiculously wonderful things about me, which, you know, is for many of us why we stay in medicine, because there really isn't anywhere else that you can get that kind of feedback that all of your years of training and all of your years of commitment and sacrifice culminates in this patient and this family's deep-seated, true, genuine appreciation for what it is you've done for them. It's just one of the most unbelievable feelings in the world to do that. But that requires a time investment. It does not require a 3-minute review of an X-ray followed by a decision. It is a true, genuine, deep time commitment to getting it right.
Okay, thank you.
Any other questions?
David, how did you get buy-in from other people on different specialties to kind of cover all these different bases? That's one of the main issues I'm having with a lot of these patients. People come in, they're diabetic, obese, with depression and osteoporotic. I ask endocrinologists to see them. They say, "Oh, I only see 5 patients in clinic in a day. I'll see them in 3 months."
Right.
You know.
Right. Right. Yeah, that is something that has taken 14 years to achieve. That certainly didn't happen overnight. And there was a lot of trial and error. You know, there were people that I thought were going to be wonderful collaborators who proved not to be such strong collaborators. But I am so blessed to, over the years, have identified these pockets of individuals who are very good at what they do, and where over time the sharing of these patients and the people on the other side seeing, you know what, that guy cares. And they will say things like, you know, I haven't met a surgeon who spends as much time on these issues as you do. And when they see that I'm not asking them to do something for me, I'm asking them to engage in a multidisciplinary process that is to the benefit of this patient, they see the rewards of that as well. And so over time, we've created these little lists, and Jacob's seen this, Anna's seen this in clinic, where I'll walk in and I'll say, I have fantastic people on the team, and I'll say, hey, who was that last person that we said, who was that hematologist that did that great thing for us, 6 months ago for that one patient? And she'll say, oh yeah, it was Dr. Smith. And so we keep going back to the same wells when you're getting that positive reinforcement that they're looking to help the patient in the same way that you're looking to help the patient. And just make sure you're cataloging those things up here and on paper, so that over time, you've got your little go-tos of the people that are as vested in this as you are. Yeah. Anybody else?
I have kind of a in the weeds question. I was wondering with this, I didn't get any training in osteoporosis in residency, and this year with Jeffrey has been the only time where it's really been focused on. But to that point of that nebulous amount of time for how long to be on Forteo,
Sure.
do you feel like it's more like for someone with a T-score minus 3.5 or something, do you want to get them up to a certain point before you intervene, or is it more that duration after surgery that seems to matter? Like, how do you balance
It's
that?
more about the duration. It's more about the duration of exposure than the T-score. So once you've identified the severe osteoporosis by T-score, you won't necessarily see the impact on the T-score that you're looking for, but you will see the impact on the biology.
Okay.
So the biology improves even if the test metric doesn't.
Okay.
And so for me, it's really about the duration of exposure. And I want the patients on it before we go to the operating room, because of how many obstacles and hurdles and hoops that have to be jumped through in order to get them on the medication. Once they're started on the medication, I know they're going to have access to the medication, right? If we're still working through that process and their surgery date's coming up, that's a problem, because it's then unclear to me how long after surgery before they actually gain access to it. So I want them on it for at least a month. I prefer for them to be on it for 3 months, but really the most important thing is that they've been on it once.
Okay.
So that as long as they've had that first dose, at least I know that the process is in place for them to gain access to the drug.
Certainly set into the night looking at adult deformity fundamentals, but really had a great discussion around patient selection and really those modifiable and non-modifiable variables that contribute to potential success in the operating room. So thank you very much for leading our discussion. A special thanks to the group for joining us. Great questions along the way. And the reason why that hour elapsed so quickly is because there was a very positive engagement amongst the group. So thank you very much, everybody. Have a wonderful evening. And as you head to the hospital tomorrow, be safe, be well. Thanks again, Dr. Okonkwo. Have a great night, everybody. Take care now.
Thank you, everybody. It was a pleasure. Real pleasure. Thank you.
Bye-bye.